Bismillah ar-Rahman ar-Rahim. Welcome everyone and to our SSBMT webinar series. This is an state-of-art webinar series for hematological malignancy. Today we have the pleasure to have a distinguished speaker, Dr. Richard Larson. Dr. Richard Larson is a professor of medicine in the section of hematology oncology, the director of hematological malignancies clinical research program at University of Chicago. Dr. Richard Larson actually is a member of multiple societies, including the National Cancer Institute Leukemia Steering Committee, and he was awarded the Henry Stratton Medal for Clinical Science in 2019. He's a member of American Society of Oncology, Clinical Oncology, American Society of Cancer Research, and European Leukemia Network. And Dr. Larson has published more than 500 paper reviews, book chapters, and clinical and laboratory studies in human leukemias. In addition, has served on editorial boards of Blood, the JCO, and Leukemia as well. Dr. Larson maintains an active clinical practice at the University of Chicago Medical Center. His expertise is widely sought for consultation regarding leukemia and myelodysplastic syndrome. Throughout his career, his research interest has included clinical trial in acute and chronic leukemias, as well as stem cell transplant. Dr. Larson, welcome, and the mic is yours.
Thank you very much. It's a pleasure to be with you this afternoon here in Chicago, and I guess the evening in Saudi. So I've opened my slides. Can everyone see those?
Yes.
So I was asked to speak on how I treat acute myeloid leukemia, and more we think in terms of targeting the malignant cells through their specific biological or genetic characteristics. Let me, I think I can advance the slides. There. So let me just say, we have a number of interactions with pharmaceutical companies through our developmental therapeutics program. You see them listed here. The companies in bold print have drugs either on the market or in development that I'll be mentioning during the talk today. So I'd like to start with this slide just to emphasize the point that we now no longer think of AML as being a single disease, but really a spectrum of multiple different sometimes overlapping subpopulations of disease. So thinking of AML as a syndrome rather than a disease, I think helps us begin to deal with the heterogeneity which has hampered, I think, progress in this area over the last several decades. So up until recently, when we encounter a new patient, we go through a diagnostic evaluation, basically to sort patients into one of two categories: young, fit patients who are candidates for intensive remission induction therapy, and perhaps then an allogeneic transplant, depending upon the risk factors, principally the cytogenetic features present at the time of diagnosis. And then an alternative category who tend to be older patients and often less fit for that reason, with comorbidities. And many of these patients were recommended to be treated with low-dose Ara-C or with hypomethylating agents, azacitidine or decitabine. Neither one really have curative potential, but this was also a fertile ground for the development of new therapies. So the landscape has changed and become more complex as we've tried to sort through the heterogeneity of AML. This may be the most important slide in my presentation today, really to emphasize that there are now multiple subsets, and for that reason, drugs have been developed to target the individual biological characteristics of these subsets. And that's led to some progress, but perhaps we'll talk about some of the pitfalls as well. Just looking down the left-hand side of this slide, again, there are patients who are eligible for intensive chemotherapy. Those with core binding factor AML appear to have a better outcome when gemtuzumab, ozogamicin, or Mylotarg is added to standard 7+3 chemotherapy. There have been randomized trials that suggest that this is the case. There are also trials suggesting that using a c-KIT inhibitor such as dasatinib or midostaurin may also improve the outcome of patients with 821 translocations or inversion 16 AML, which are collectively known as core binding factor AML. The FLT3 mutant group has been a target for a number of drug companies to develop inhibitors. We'll spend most of the next half hour talking about those. Over on the right-hand side, therapy-related AML or AML with myelodysplasia-related changes. We have a drug called CPX-351, or Vyxeos is the trade name, that was approved based on a randomized trial specifically for this subset of patients. And then further down in the yellow boxes, there's uncertainty now about those patients who have an IDH1 or 2 mutation, whether they should receive an IDH1 or 2 inhibitor, either as part of induction or post-remission therapy. And for those with intermediate risk cytogenetics, whether there's any advantage to maintenance therapy or the use of venetoclax combinations. And of course, stem cell transplantation for those patients who have adverse risk factors and can tolerate the intensity of an allogeneic transplant. On the right-hand side are those patients in the red boxes who are considered ineligible for intensive chemotherapy, either because of older, I see we have a pointer, because of older age or comorbidities. And actually there's been considerable progress here, particularly with the addition of venetoclax to hypomethylating agents or to low-dose Ara-C. And I mentioned on the previous slide that those relatively gentle chemotherapies have been used for older patients, sometimes inducing an anti-leukemic response, but very rarely complete remissions. But interestingly, when venetoclax, the BCL2 inhibitor, is added to hypomethylating agents, then we've seen surprisingly good results for older patients. These patients still go through a period of myelosuppression, and sometimes it can be prolonged neutropenia, but they seem to be spared the toxicity of cytarabine and anthracycline based chemotherapies. And again, whether the specific FLT3 inhibitors and the IDH2 inhibitors have much to add to this subset of patients, I think remains to be determined. It's not all straightforward, however. When we start identifying genetic targets, there may be a principal target, but there are often multiple mutations present in an individual patient. And if you look at the yellow area of this Circos plot, these are the patients with FLT3 mutations reported in an Eastern Cooperative Oncology Group study a number of years ago. So FLT3 is mutated in up to about 30% of patients with AML. But you can see a considerable fraction of these patients also have an NPM1 mutation. Some of them have a DNMT3A mutation and other co-mutations. And it's not always clear which is the driver mutation and which are secondary mutations. But we're going to spend time talking about FLT3. First, I want to just make sure you have an understanding of the current European Leukemia Net risk stratification of AML by genetic features. This was last published by Hartmut Donor and colleagues in Blood in 2017. So it's a combination of cytogenetic features and molecular features, and then divided into risk categories in terms of likelihood of response and overall survival. So, and importantly, it's still a work in progress as new therapies are developed and new genetic lesions are identified. But in the favorable group are the core binding factor AMLs with an 821 translocation or inversion 16. In addition, patients with mutation in the NPM1 gene, either by itself or with a low mutation fraction of FLT3 internal tandem duplications. And then finally, biallelic mutations in CEBP alpha. The intermediate group, again, starts with mutated NPM1 mutations, but here co-mutation with a high mutation fraction in FLT3 ITD puts these patients into an intermediate group. Then patients with wild type NPM1, either with or without a FLT3 mutation, patients with a 911 translocation and other cytogenetic abnormalities fall into this group as well. The real bad actors are shown here in the adverse risk category. Patients with a 6-9 translocation, many of whom will have FLT3 mutations, but this seems to be a secondary change in these patients, and FLT3 may not play a driving role here. Patients with abnormalities or rearrangements in the MLL gene on 11q23, KMT2A is the other name for that gene, fall into the adverse risk group. Inversion 3, clearly an adverse risk group. Patients with deletions of 5q, loss of 7, loss of 17, or abnormalities of 17p, where p53 resides. Patients with complex karyotypes have a low CR rate, and even those who do go into remission tend to relapse if only cytotoxic chemotherapy is given. Most of those patients should probably go on to a transplant. Here we find FLT3 ITD with a high mutation fraction showing up, as well as mutations in RUNX1, ASXL1, and TP53. So we're going to focus on the FLT3 mutant subtype of AML. It's clear that FLT3 signaling pathway is important in the proliferation of AML cells, apoptosis, and differentiation. As I pointed out, its prevalence in AML is about 30%, and about 20% of those have an internal tandem duplication or a length mutation, and another 5 or 10% will have a point mutation in the tyrosine kinase domain. In a subsequent slide, we'll look at the pathway itself. But in any case, the presence of one or more of these mutations seems to have an adverse effect on the outcomes in AML. So FLT3 inhibitors have been developed and have been tested both in the front line as well as in relapsed and refractory patients. Now, the central hypotheses for FLT3 inhibition in AML are shown here. The first one is that activated FLT3 contributes to proliferative and survival signals in AML blasts. There seems to be fairly good agreement that the evidence support this hypothesis. Secondly, that inhibition of FLT3 may have a therapeutic benefit in AML, similar to that seen with inhibition of BCR-ABL by imatinib in CML and blast crisis. And I think that's a little more speculative now. Certainly, we're less confident that FLT3 is a driver mutation that's fundamental to the disease in the way that BCR-ABL is. But the concept of using a tyrosine kinase inhibitor to downregulate that signaling and proliferation pathway remains valid. So here you see the pathway. FLT3 is overexpressed in AML. When the normal FLT3 ligand binds to the receptor, it dimerizes and activates a signaling pathway that allows proliferation, differentiation, and survival of hematopoietic stem cells. That's its normal function. When FLT3 is mutated, it allows for constitutive activation of the FLT3 pathway. Interestingly, about 80% of AML patients overexpress FLT3, and then again, about 30% have mutant FLT3 where it's constitutively activated. And it's been known really since FLT3 mutants were identified 20 years ago that FLT3 internal tandem duplication was a predictor of poor prognosis. The survival curves on the right are reflected in the actual data in the table on the left. And you can see that the 5-year relapse rate in this large series of patients from the United Kingdom, the relapses with the FLT3 ITD subset were 64% by 5 years versus 44% for those who had the wild type gene. Disease-free survival was also reduced from 46% to 30% in the presence of the mutation, and this impacted clearly on survival, being reduced from 44% to 32%. These data are from the German AML study group, looking specifically at a group of younger AML patients under the age of 60 who had cytogenetically normal AML, so removing both the favorable core binding factor subgroup as well as some of the cytogenetically adverse risk group. But even within the group of patients who had a normal karyotype, you can see that the NPM1 mutant subgroup, if FLT3 ITD was not present, had a favorable outcome with the relapse-free survival almost 60% over nearly 10 years' time. But in the lower curve, those patients who had a FLT3 ITD, and these were cases that were identified retrospectively, so the treatment was identical in the front line, but you can see how rapidly the patients with a FLT3 ITD relapsed over the first 1 to 2 years' time, so that the relapse-free survival and the overall survival by 8 to 10 years was considerably inferior to those patients who lacked the mutation. The level of the mutation also seems to be important, and we speak in terms of the allelic ratio, or the fraction of mutant alleles to wild type alleles. These again are data from clinical trials done in the United Kingdom, over 1,400 AML patients. You can see in the top black curve labeled wild type, this was the survival of patients who lacked a FLT3 mutation over 5 years' time. But as the mutation increased in percentage, in the red curve, less than 25% FLT3 ITD, in the green curve, 25 to 50%, the survival declined. And in the lower blue curve are patients with more than 50% of the allelic ratio being FLT3 ITD. And again, you can see a rapid relapse rate. Many of these patients relapsed and died within the first year, and there were only 15% of those patients still alive at 5 years' time. Now, shown here are a number of the agents that have been developed specifically to inhibit FLT3. These are kinase or kinograms. These are show the evolutionary tree of kinases in human cells. If you start in the top left, the panel labeled AC220 or quizartinib as it's known now, you can see the large red dot in the top left. That represents the inhibitory concentration of quizartinib against the FLT3 kinase, the FLT3 tyrosine kinase. So you can see that quizartinib also has a lesser effect against a few other kinases, but is highly specific for FLT3. If you move one to the right, the dendrogram labeled lastortinib, you can see that this particular agent also inhibits FLT3, but is actually a multi-kinase inhibitor, as is true of midostaurin, which is in the lower left corner. You can see it also inhibits midostaurin, also inhibits FLT3, but is a multi-kinase inhibitor. This drug went through phase 1 and phase 2 trials and eventually was approved in the front line for patients with FLT3 mutations, and I'll show you those data. So the phase 3 trial of midostaurin in AML, which resulted in its approval, both by the FDA in the United States and the European Medicines Association in the agency in Europe. This was the paper in the New England Journal published in 2017 reporting on this trial, which was led by the Cancer and Leukemia Group B, or now called the Alliance, but really required the participation of 13 different cooperative groups around the world in order to accrue these patients. This is the schema for what has become known as the RATIFY trial. You see it starts with screening patients. And although FLT3 mutation is one of the most common, is the most common abnormality in AML, over 3,500 newly diagnosed AML patients had to be screened in order to enroll 717 patients who had either an internal tandem duplication mutation or a tyrosine kinase domain point mutation. So those were the only patients who were eligible to enroll. They were stratified according to the point mutation or the ITD mutation with a mutant allele fraction less than 0.7 or greater than 0.7, which was thought to be approximately the median value. We now think that the median value may be closer to 0.5, but it did stratify patients in approximately equal numbers and in these three risk groups. So the patients were randomized either to a standard daunorubicin for 3 days and Ara-C for 7 days, together with a blinded, double-blinded oral placebo in the lower red arm of the curve of the trial, or to the experimental arm where midostaurin was given. And midostaurin was started on day 8 after the end of the 7-day cytarabine infusion and given for 2 weeks time. If midostaurin is given concurrent with Ara-C and daunorubicin, it tends to cause intolerable nausea and vomiting. So this drug has to be given after the cytotoxic therapy. Patients who entered remission then got high-dose cytarabine together with the study drug, either midostaurin or a blinded placebo, for up to 4 cycles, and then were eligible to continue on just the study drug alone as a maintenance therapy. Midostaurin's oral, can be taken twice a day for 12 months' time. Anywhere along this pathway, physicians were allowed to send patients to an allogeneic transplant if they thought that was in the patient's best interest, and we'll talk about that. So midostaurin was approved in combination with intensive chemotherapy based upon the data shown in this slide, a 22% reduction in the risk of death shown in the blue arm, extending out to 7 or 8 years compared to the placebo arm. So a hazard ratio of 0.78 and a p-value of 0.009. So one of the first trials to show a survival advantage for a new agent used in the front line in AML. And that's shown in this forest plot, again in the top line, the overall survival for all 1,717 patients clearly favored those on the midostaurin arm. Again, you see the hazard rate of 0.78. Now, the 3 strata, FLT3 ITD with a high allelic ratio, the FLT3 ITD with a low allelic ratio, and the FLT3 TKD group all favored the midostaurin arm, but didn't meet statistical significance, and the trial was not really powered to look at these 3 strata separately, but it was reassuring that they were all in the same direction. As I mentioned, allogeneic transplantation was allowed within the context of the trial. Here you can see that approximately equal numbers of patients underwent a transplant in first remission, 100 patients on the midostaurin arm, 81 on the placebo arm. There was no statistically significant difference in the percentage of patients who underwent a first remission transplant. The study drug was stopped prior to the transplant and was not restarted after the transplant. Those patients who relapsed, of course, once they went back into remission, were often transplanted in second remission. So here you see the number of patients transplanted at any time. So it was 59% of those on the midostaurin arm and 55% on the placebo arm, bearing in mind that once patients relapsed, they also stopped the study drug, and that may have had an impact on the outcome of these second CR transplants. And that's shown in this slide. So here you're looking at the overall survival from the time of transplantation, and the top 2 curves are patients who underwent a allogeneic transplant in first remission. So they were still on the study drug up until the time of transplantation. You can see in the dashed blue curve the more favorable outcome for patients who had been on the midostaurin arm and underwent a transplant in first remission. The interpretation of this is not entirely clear because there was no measurement of minimal residual disease done within the trial for those patients just before transplantation, but it suggests that the remissions that were achieved on the midostaurin arm were perhaps deeper or more durable, so that the relapse rate after the transplantation was less common. The lower 2 curves are the patients who underwent a transplant outside of CR1. So these patients presumably relapsed, were reinduced, and then had a transplant in second remission or perhaps even third remission. And of course, they were no longer on the study drug after they relapsed. And here there was no difference in the outcome in terms of survival after these later remission transplants. Now, going back to the genetic risk classification scheme of the European Leukemia Net, which divided patients into favorable, intermediate, and adverse risk groups, this particular survival curve looks at the patients enrolled on the RATIFY trial who had had NPM1 mutation analyses done, and of course they all had FLT3 ITD mutations in order to go on that trial. But you can see that the ELN risk groups did stratify patients according to survival, even within the context of this trial. So in the top black line with the 95% confidence gray bars around it, you see the outcome of those patients who would have been classified as ELN favorable based on an NPM1 mutation and a low FLT3 ITD allelic mutation. And then in the red curve are the intermediate patients, so FLT3 mutation with an NPM1 mutation, and in the green curve are patients who were FLT3 wild type but had a FLT3 ITD mutation. So here the three risk groups are broken out separately in three different graphs: favorable, intermediate, adverse risk group. And now what you see are the patients who had gotten midostaurin versus the placebo within each of those risk groups. Within each of those risk groups, together with the 95% confidence limits. And you can see that there appeared to be a favorable outcome within each risk group, perhaps the greatest benefit within the adverse risk group when the FLT3 inhibitor midostaurin was used. We'll go on to the next slide. So I've been asked to use the pointer, so I'll try that. So midostaurin's not the only FLT3 inhibitor that we have available. We'll talk about some of the others. Here you see the kinase dendrograms again, and we'll get the pointer working. I hope you can see my pointer now. Quizartinib being very highly specific, lastartinib being a multi-kinase inhibitor, sunitinib also being a multi-kinase inhibitor. Gilteritinib's not on this slide, but we'll talk about that one. Let's review lastartinib first. This was actually the first FLT3 kinase inhibitor that went into a frontline randomized trial. These are data from the United Kingdom. And you can see in this particular trial, there was no survival advantage when lastartinib was added to standard frontline chemotherapy. And I believe this agent is no longer being developed. Here are three drugs that you may be familiar with. We'll start with gilteritinib in the lower bottom row here. Has a long half-life. It's a once-a-day drug. It was approved by the FDA in the United States about 1.5 years ago for relapsed and refractory patients. And it's now in phase 1 and 2 trials, actually in phase 3 trials in combination with chemotherapy in the front line. Quizartinib will probably be the next drug that will be approved. Its application is pending now at the FDA. It also has a long half-life. It's a highly specific drug, although interestingly, it also inhibits KIT. It's completed its phase 2 trials in relapsed and refractory disease. Phase 3 trial is ongoing in frontline patients. It's actually completed accrual, and the data are at the FDA for approval. And then there's a newcomer called crenolanib. Crenolanib has a disadvantage of being a short-acting, short half-life drug. It has to be given 3 times a day, but it's also in phase 3 trials with intensive chemotherapy, and we'll see how that pans out. We'll talk a little bit about gilteritinib because that is an approved and commercially available drug for relapsed and refractory AML with mutant FLT3. This is the schema for the Admiral trial, which was for relapsed or refractory FLT3 mutant AML. There was a 2-to-1 randomization. So twice as many patients were randomized to the gilteritinib arm. The standard now 120 milligrams once a day dosing versus salvage chemotherapy, which could be the physician's choice of any of the standard regimens listed in the lower box. For the patients randomized to gilteritinib, if they had a good response and could go on to a transplant, many of them did an allogeneic transplant, and some of them received gilteritinib post-transplant. If they were not a candidate for a transplant, then they continued on gilteritinib. This is the outcome looking at overall survival by the intention to treat population. The blue curve is the gilteritinib curve. Again, these are relapsed refractory patients. The hazard ratio here is 0.63. The p-value is 0.0007. So a highly significant difference, although a little disappointing that these patients are not having long-term survival. This is the 2-year point, and the only long-term survivors here are generally the ones who underwent an allogeneic transplant. This is the same trial, again, looking at the intention to treat population. In the top left curve, here patients have been censored at the time of transplant. The more interesting curve is the lower right. I mentioned a number of patients, both on the gilteritinib and the placebo arm, underwent allogeneic transplants. This curve looks at the survival of patients in the blue curve who restarted the gilteritinib versus the patients who did not restart the gilteritinib. So they had gilteritinib during induction of their relapse disease, but after transplant, for any number of reasons, apparently did not restart gilteritinib. So this is not a randomized comparison post-transplant, but seems to suggest that those patients who are able to restart gilteritinib may benefit from doing that. It's important to recognize when using these drugs that they're not necessarily cytotoxic. They do induce differentiation, and that's shown in part in these photomicrographs. Looking at this field of myeloblasts prior to gilteritinib and post-gilteritinib, patients can enter remission without going through a period of marrow hypoplasia, and you can see, hopefully, the differentiated neutrophils here. This is important, of course, if you're using a genetic test to follow the response, because even though these neutrophils appear to be normal and mature, they still manifest the FLT3 mutation. So the PCR analysis will come back positive, even if they achieve a hematologic remission. The other drug to become aware of, I think, will be quizartinib. This is among the most potent and specific of the FLT3 inhibitors. You can see down here the IC50 in nanomolar, both in tissue culture media, but also in plasma, considerably more potent than the other FLT3 inhibitors shown here, including midostaurin. As I mentioned, quizartinib is going through the clinical trials process. Importantly, it also induces blasts to undergo terminal differentiation. And again, that's shown here, myeloblasts prior to treatment. Day 15, you're starting to see a nuclear HOF as these blasts become myelocytes. And here now, they've matured to neutrophils. And all of this happens with no change in the overall cellularity between day 1 and day 29. So it's important to recognize that important feature of these drugs. So let me summarize what we've talked about. First, FLT3 mutations are common in AML, both the internal tandem duplication and the point mutation in the tyrosine kinase domain. These FLT3 mutations are associated with rapid relapse after achieving a CR, that the fraction of mutated to wild type genes, known as the allelic ratio, does impact on the clinical outcome. People with a low allelic ratio clearly have a more favorable outcome than those with a high allelic ratio, homozygosity or hemizygosity. Next, FLT3 inhibitors do block FLT3 signaling. FLT3 inhibitors can reduce the number of circulating blasts. FLT3 inhibitors can be safely combined with chemotherapy. That's true of midostaurin, although not concurrent. It has to be a sequential midostaurin. The FLT3 randomized trial did show a survival of benefit when midostaurin was used after chemotherapy for FLT3 mutant AML. Next, gilteritinib has been approved for relapsed and refractory FLT3 mutant AML and is now being evaluated in frontline randomized trials. Quizartinib will likely soon be approved for relapsed and refractory FLT3 ITD positive AML and is also being tested in the frontline. So both gilteritinib and quizartinib are moving into frontline therapy as they're being tested versus midostaurin containing regimens. So I'll stop there. This is a photograph of the University of Chicago here on the south side of Chicago, and I hope you've enjoyed this presentation and benefited from it. So I think we have some time for questions. So I see one question has popped up. Are examination of peripheral blood smear and bone marrow smear enough for the diagnosis of leukemia, or should be followed by cytogenetic studies? So clearly, I think if there are leukemic blasts out in the blood, you can make a diagnosis of leukemia. Where cytogenetic and molecular studies become important is in the risk assessment, increasingly to pick the initial induction therapy, but perhaps more importantly to choose the right post-remission therapy. So it can still take a week or two to get cytogenetic results back. It can take a week to get some of the genetic next generation sequencing results back. You can get FISH analysis on the blood back in a couple of days, and you can FISH for the commonly occurring molecular rearrangements in AML to help choose the initial therapy. But I think increasingly you want to do a full panel of diagnostic evaluation for newly diagnosed patients so that you can begin to plan for a transplant for those patients with adverse features who are not likely to be cured with chemotherapy. Alternatively, for someone with core binding factor AML, You might want to incorporate gemtuzumab into initial therapy, and you might not transplant such a patient in first remission.
Great. Dr. Larson, I think Dr. Badi got disconnected. However, it was elegant and a great talk. So you answered the first question, and we'll go ahead with the second question. So in your practice, what is the allegation point do you consider to initiate inhibitor?
So is this a question about institutions that don't have cytogenetics?
No, that's related to the allelic ratio, the FLT3 inhibitor. Yeah.
So the allelic ratio cut point for to initiate a FLT3 inhibitor. So in the clinical trial, to be called positive, the allelic ratio had to be greater than 0.05, so at the 5% level. I think if you're using a PCR test to detect FLT3, that's probably at the threshold of a true positive versus a false positive or false negative test. So 0.05 for the allelic ratio. Anything above that, we would call FLT3 mutant and use midostaurin as part of initial induction. As you saw, the three different strata in the ratified trial all showed a benefit for midostaurin, although it wasn't statistically significant because the trial wasn't designed with sufficient power within each of the strata. But the apparent benefit for the low allelic ratio patients, so between 0.05 and 0.7 in that trial, seemed to be as great as those with a high allelic ratio.
Right. Another question. Now, maybe you could talk about, is there a role for maintenance here, and how you foresee the maintenance AML using ovates?
I'm sorry, the voice was breaking up a bit. Can you project the question? It was something about maintenance.
Yeah, I mean, anything considered maintenance, would you consider, how do you foresee the novel agents integrate to maintenance?
So this has to do with using midostaurin for maintenance in the ratified trial?
Yes.
So I'll address that and then we'll make it more generalized as well. So in the ratified trial, patients who did not get a transplant were allowed to continue on study and get 12 additional months of the study drug. However, there was no second randomization. So although the groups were approximately equivalent, it was really hard to separate out any specific advantage to the maintenance therapy. Now, interestingly, when the EMA approved the use of midostaurin in the European Union, they specifically included midostaurin within maintenance within the approval. On the other hand, the FDA in the United States did not mention maintenance and just approved midostaurin in combination with intensive chemotherapy, which most of us have taken as sufficient to justify giving maintenance. But there was no difference in the disease-free survival for patients from the start of maintenance, regardless of which arm of the trial they were on. So there were slightly more relapses during the 12 months of maintenance if patients were on the placebo arm, but once the study drug was done, there were slightly more relapses in the patients who had been on the midostaurin arm. One explanation could be that the midostaurin was suppressing the relapse, but not completely preventing it, so that it occurred once a relapse was finished. Now, with regard to maintenance therapy for AML in general, it's not clear that there's an advantage, but we probably don't have the right maintenance drugs yet. There was a trial recently reported using oral azacitidine, CC486, in older patients with AML who entered first remission. And it's clear from that trial that CC486 oral azacitidine did prolong the remission-free survival in that group of patients versus a placebo. So that drug has, I think, not yet been approved in any country, but I suspect it will. I think the data are quite compelling, at least for older patients. Again, whether it has any curative potential or just delays relapse is the question. Other attempts using either decitabine or azacitidine as injectable maintenance drugs have been tried, and it's been hard to draw conclusions from the phase 2 trials that have been done. So in general, I think maintenance still is not proven to be beneficial, at least outside of the FLT3 cases.
All right. Do you hear me?
Yes, I can hear.
Okay, good. I get disconnected here. I don't know what happened. I'm not sure which question you reach at. There's a question about benefit versus complications of FLT3 and COVID-19. Did we talk about this question?
No, I haven't addressed that yet. And frankly, there's not too much to add. Specific to the FLT3 mutant AML, or frankly to any of our leukemia patients going through intensive chemotherapy at a time that they're at risk to develop a coronavirus infection. So we screen all of our patients by PCR on nasal swabs prior to their entry into the hospital, and then we screen them again 2 days later. I think if someone were positive and it was possible to delay chemotherapy, we would delay and try to get them through the symptomatic phase of a COVID-19 infection. But not every patient can delay their treatment. Certainly, we reduced our transplant program during March, April, and May to try to keep patients out of the hospital at a time that we had over 100 COVID-19 patients in the hospital at any one time. We did participate in the remdesivir trial here. We think that that antiviral probably does have some benefit. We've given convalescent plasma to some of our patients who have had COVID-19, and we think that there's some benefit there. But specifically with regard to FLT3 or the FLT3 inhibitors, I'm not aware of any data that it changes the risk or the outcome after a COVID-19 infection.
All right. Another question talking about what is the platelet parameter during the midostaurin treatment?
I'm sorry, what is, say again?
The platelet parameter during the midostaurin treatment, yeah.
Yeah. So midostaurin by itself is not particularly myelosuppressive. So during the 12 months of maintenance therapy, there were very few patients who needed any transfusion support, and most patients were not on prophylactic antibiotics either. So in patients in remission, midostaurin, I think, is not myelosuppressive. When midostaurin was used as a single agent to treat relapse disease, there is some myelosuppression there, but it's hard to sort out whether that's related to the underlying leukemia or not. So it seems to be a safe drug to use during maintenance.
All right. Another question is about the use of sorafenib if midostaurin is not available.
Yeah, that's a good question. So sorafenib, of course, is a RAF inhibitor, originally approved for kidney cancer. But as we've spoken about, these kinase inhibitors often inhibit multiple kinases, and it was recognized quite quickly that sorafenib also inhibits FLT3. And there have been a number of trials, some of them phase 2 trials, but some of them randomized trials that suggest a benefit for using sorafenib for FLT3 mutant AML. So I think in the absence of midostaurin, if you have access to sorafenib, it's reasonable to consider that. A note of caution, there was a randomized trial done in Germany where the patients on the sorafenib arm had a less good outcome than the patients on the control arm. But there was a follow-up trial called the SORAIN trial, also done in Germany, where there appeared to be a benefit using sorafenib together with intensive chemotherapy for FLT3 inhibition. That trial's a little difficult to interpret because many of those patients went on to a transplant, so it's a little difficult to sort out how many of them actually got benefit from sorafenib. But we've certainly used it in the days before midostaurin was available.
Okay. So next question is about interruption of FLT3 inhibitor during febrile neutropenia. Do you interrupt the treatment?
Good question. And our practice is not to interrupt the FLT3 inhibitor. So that's generally midostaurin in the front line. So during remission induction, the midostaurin is given days 8 to 21, which is the high risk period for neutropenic fever. We culture patients, we put them on broad spectrum antibiotics, but we keep the midostaurin going. It does not appear to delay recovery of neutrophils. And of course, the midostaurin was used after high-dose cytarabine for those patients in remission getting consolidation therapy, and neutropenic fevers are slightly less common then, but again, we would not interrupt the inhibitor. The other situation is the use of gilteritinib treating relapsed or refractory patients. That may be a little more problematic because you're less confident that they're going to go into remission, although the remission rate, complete and partial remission, is fairly high with gilteritinib in relapsed disease. But again, we would add antibiotics, antifungal drugs, and keep the gilteritinib going for the most part.
All right. I think we will conclude at this point. We get a lot of questions. I do apologize for those questions that we could not answer during this session. I would like to thank Dr. Larson for being with us tonight during this distinguished webinar. And I would like also to remind you about our upcoming How I Treat CML Who Failed Prior Therapy next week. Thank you so much, Dr. Larson. It's a pleasure to have you tonight. And thanks to our audience for continuing supporting the SSBMT and SSBMT webinar.
Thank you, Dr. Bader.
Thank you.